Welcome everyone to our August Prime NUS-PRIME session. So NUS-PRIME stands for Priority Research in Medical Education, and we have these sessions every first Monday of the month. So same as other month, okay, we have two speakers for this month, and one is coming from Taiwan, the other one is from Singapore. So before I invite the first speaker, let me introduce you the bio of the first speaker. So Dr. Chang-Chyi is a nephrologist and senior physician educator at Linkou Chang-Chyi Memorial Hospital. She served as the director of the Center of Medical Humanities. He also served as director of Department Medical Humanities and Social Sciences at Chang-Chyi University College of Medicine. And all the research that he has been focusing on is basically on medical humanities and clinical reasoning. So today we will have to hear from him one of his presentation on reflecting on medical humanities education and practice amid the pandemic, a Q methodology approach. So let us welcome Dr. Chen. And he has recorded his presentation. Please prepare your questions and we will have him to come on board to answer all the questions that you have after the presentation. Thank you.
I am Chang-Chyi JENQ, a nephrologist and a medical educator at the Linkou Chang-Chyi Memorial Hospital in Taiwan. It's truly an honor to join this
Sorry, Sophie, I can't hear the sound.
Study titled Reflecting. Ladies and gentlemen, I am Chang-Chyi JENQ, a nephrologist and a medical educator at the Linkou Chang-Chyi Memorial Hospital in Taiwan. It's truly an honor to join this forum and share our study, titled as Reflecting on Medical Humanities Education and Practice Amid the Pandemic, a Q methodology approach. This work was conducted by a cross-institutional team, including faculty and researchers from Chang-Chyi Memorial Hospital, Chang-Chyi Medical Education Research Center, and the Chang-Chyi University College of Medicine. The concept of medical humanities originated in Western medical education in the late 19th century, particularly in response to the growing dominance of biomedical science. It aimed to restore humanistic thinking, narrative understanding, and moral sensitivity to medical training. In Taiwan, medical humanities gained momentum during the 1992 medical education reform, when holistic care, professionalism, and doctor-patient communication were brought into sharper focus. Since then, humanities courses have become a standard part of most medical curricula. However, in practice, there remains a tension between ideal and reality. Students often struggle to connect classroom discussions of ethics or empathy with the fast-paced demands of clinical care. The COVID-19 pandemic only deepened this challenge, disrupting face-to-face learning, straining hospital systems, and placing learners in an environment of uncertainty, isolation, and moral distress. In this context, we wanted to explore how did medical learners perceive and apply the value of medical humanities during the pandemic. That became the central question of our study. We designed a four-stage study. conducted from August 2022 to July 2023. In Stage 1 and 2, we focus on qualitative exploration, recruiting 20 participants across different training levels, ranging from preclinical students to PGY physicians. We conducted 4 focus group interviews, using open-ended questions to surface lived experience and perceptions. In Stage 3 and 4, we transitioned into a structured analysis using Q methodology, enrolling 80 additional participants. This mixed method approach allows us to examine how learners' subjective views clustered into shared patterns, giving both depth and structure to our findings. This design reflects our belief that the humanities cannot be evaluated through score only. We need methods that can capture ambivalence, diversity, and personal meaning, and the Q methodology was ideal for that purpose. From the focus group transcripts, we conducted thematic analysis, which generated over 300 initial codes. After careful consolidation, we refined this into 133 Q statements, each representing a unique opinion or belief about medical humanities. To ensure content validity, we consulted 8 domain experts through the Delphi method, who helped us categorize and validate the statements. Ultimately, we organized the Q statements into 3 thematic groups, reviewing the learning experience of the medical humanity curriculum, influencing medical humanity practice, and the impact of COVID-19 on medical humanities. Each theme was developed into a separate Q sorting text, where participants ranked statements based on how much they agree or disagree. This forced choice method helps to reveal not only what learners value, but also what they are conflicted about. In the following slides, I will walk you through the results of each theme, highlighting key factors, representative voice, and the implications they carry for curriculum design. To analyze learners' subjective viewpoints, we employed Q methodology, which blends both qualitative richness and quantitative structure. Using the online platform, we conducted factor analysis and principal component analysis to cluster participants with similar response pattern. We applied the agent value more than one rule to retain factors, and determined when to stop based on the screen plot, looking for a point where the curve flattened, which indicating diminishing returns. This process allowed us to reduce 133 Q statements into a manageable number of explanatory factors, essentially. Shared perceptives that reflect dominant thought patterns among learners. For each factor, we selected anchor participants whose Q thought were highly correlated with the factors to help interpret and name the latent viewpoint. This mixed method approach offered not only structured grouping but also preserved individual nuance, and voice. A key advantage in medical education research. The first thing, reviewing the learning experience of the medical humanities curriculum. Focus on how learners retrospectively made sense of their humanity education. A common reflection was that early exposure to medical humanities felt vague or unrelated to real medicine. Many learners felt overwhelmed by basic science and clinical content, and the humanities courses were sometimes perceived as less essential. However, as learners progressed into the clinical phase, especially those in PGI-2, as seen in Factor 3, they began to re-evaluate their earlier learning. They describe how previous discussions on empathy, person-centered care, and communication suddenly become relevant, especially when facing ethical dilemmas, distressed patients, or complex family dynamics. This trajectory reflects that many researchers have called the delayed relevance of the humanities. They make more sense once learners encounter the messy, emotional reality of clinical practice. Thus, the humanities curriculum can act like a scaffold, providing concepts and a vocabulary that learners draw upon later. In emotionally charged moments of care. We then turn to the second theme, influencing medical humanities practice. This phase of the study sought to understand how humanities learning translates or fail to translate into actual clinical behavior. We again performed factor analysis and extracted 4 distinct clusters of learners. You will see in the next slide how these groups emphasized different aspects of applying humanities in practice, from bedside empathy to professional identity. In this theme, participants explored how the value taught in medical humanities will or will not integrate into their clinical work. Across Factor 2 and 3, led by PGI-2 learners, a strong sentiment emerged. You don't really learn empathy in lectures, you learn it on the ward. They describe how engaging with distressed families, breaking bad news, or caring for dying patients required not only technical skill, but emotional presence, listening, and moral clarity. This aligns with experiential learning theories, which suggest that cognitive understanding alone does not produce behavior change. It must be reinforced through reflection and lived experience. Interestingly, participants also emphasize that institutional culture matters. Some learners feel that in hierarchical or rushed environments, there was little room to practice what they had learned about empathy and ethics. This points to an important takeaway. Teaching humanities isn't enough. We also need supportive clinical environments to model and reward humanistic care. Our third and final theme was the impact of COVID-19 on medical humanities. Here, we sought to understand how an external systemic-wide crises like the pandemic reshaped learners' thinking about the humanities. Once again, QMA's results revealed a spectrum of views, which we will explore more closely in the next slide. During the pandemic, the shift to online medical humanities education significantly limited patient contact. This reduced opportunities for learners to cultivate empathy and communication, core values of the humanities curriculum. These challenges were highlighted in Factor 2 and 3, both of which were led by PGI2 trainees. They expressed frustrations over the lack of real-life human interaction, which hindered emotional engagement and the development of bedside manner. At the same time, Factor 4, led by M5 students, presented a contrasting view. This group saw the pandemic as a rich learning environment, one that surfaced ethical dilemmas, professional responsibility, and crisis management issues, deeply resonate with the humanities. This duality, loss of connection versus growth in reflection, demonstrates how learners at different stages engage with the pandemic in very different, yet complementary ways. Building on the previous slides, we observed that learners' experience was strongly shaped by their clinical exposure. Senior learners had a deeper appreciation of holistic care and the practical application of medical humanities, especially in empathy and communication. By contrast, junior learners viewed the pandemic as a unique opportunity to explore ethics, professional identity, and systemic challenges, issues they might not otherwise encounter so vividly. These dual perspectives, the loss of human connection versus the growth in ethical reflection, captures the multifaceted impact of COVID-19 on both education and the practice of medical humanities. It also illustrates how the pandemic reshaped teaching approaches and doctor-patient interactions, further influencing how learners value the humanities. In conclusion, this study explored how medical learners engaged with medical humanities during the COVID-19 pandemic. By combining focus group interview with Q methodology, we were able to identify three key themes that reflected learners' evolving experience and perceptions. First, many participants share that meanings of medical humanities only become clear once they enter clinical settings. Topics like empathy, suffering, and person-centered care gain relevance when faced with real patient encounters. Second, learners express both the value and the difficulty of applying these humanistic principles in practice. While they recognize the importance of active listening and holistic care, time pressure, institutional culture, and hierarchy often limited their ability to act on these values. Third, the pandemic had a dual impact. On the one hand, it disrupted face-to-face interaction, reducing opportunities for connection. On the other hand, it encountered deeper reflection on ethics, responsibilities, and the emotional changes of medical work. Importantly, we found that learners' perspectives were shaped by their stage of training. Senior learners emphasized clinical communication and emotional presence. Junior learners tended to focus more on abstract ethical reflection and systemic concern. These findings suggest that medical humanity education should not be a one-time event. Instead, it should be integrated throughout the medical journey, with content and reflection opportunities that match learners' developmental stage. Finally, while curriculum is essential, it is not enough. We also need a supportive learning environment that encounters discussion, models compassion, and reinforce the value we hope to teach. Because in the end, as the study reminds us, humanistic physicians are not born, they are cultivated. Thank you for your attention. I welcome any questions or feedback.
Thank you so much for the presentation. Okay. Please do feel free to put in your question in the chat and I will address your question later. So just a question from me to Dr. Zheng. How is the medical humanities curriculum like in Chang-Chyi University? Can you roughly describe it to us?
Thanks for your question. In the Chang-Chyi Memorial Hospital and Chang-Chyi University, we have 18 score of the medical humanity curriculum, and it spans from the first year to the sixth year in the medical school, College of Medicine. And we have divided them into 3 groups. The first one is we placed in the first year and the second year, and we want to establish their basic knowledge about medical humanities, such as the content about social science and physiology field, and something the theory about life and death. And then in the second stage, we arrange humanity course, such as the life and death course after the anatomy class, and the students will feel more link from the patient, from the anatomy class to the humanity knowledge. So and in the third stage, we put some narrative writing and humanity case discussion in the clinical course, just in their final 2 years. And they will link their medical humanity knowledge from the class in the school to the clinical practice field. This is the picture about our humanity course setting. Thank you.
Thank you so much for describing it. Then can I ask what changes has been done after this research was conducted?
Okay, because in the goal of this study, we want to know, we try to know the thinking and the thought about the humanity course from the students, because we found that because the medical humanity course is not the main course in to the medical student. So our humanity teacher see maybe they found that many of them did not pay much attention to our course. So we want to know what they think. And in this study, we found that maybe we can maybe more students than we think have interest in this course. However, they did not know the effect of this course when they are junior. So after they have experience in the clinical setting, they feel that this humanity course is important to their career. So maybe we, according to these findings in this study, maybe we try to link them from the school to the clinical setting by enhance or increase the case or some simulation training, not only the clinical skill, but also the communication skill and the communication encounter. Maybe they will feel that the medical humanities course is more important, equal to their basic and clinical medical knowledge during their learning. Thank you.
Thank you so much. I think a lot of time when they were in year one, they don't see the importance of medical humanities. It's the same across a lot of medical school. So there are two questions coming up. I know the time it's up as well. I'll just take one question. Hope that's fine, Guotong. Right. So you mentioned that medical humanity is a Western concept. So your study is in Taiwan. So do you have any findings regarding to a more East Asian version of medical humanities?
Yes, thanks for your wonderful question about a cultural issue in the humanity course. I found that in effect some students mentioned that even they learn hard about the medical humanity course in the school, when they observe that their teachers in the clinical setting will not behavior as the humanity principle, they will feel that something not very they feel not good when they found that the medical humanity rules and principles will not be used in the clinical setting. So we think that in our study, we also find that maybe the faculty development of our clinical teachers may be one of the rules to improve our medical humanity education. Yes.
I see. I think what I gathered from you is there are some principles maybe mentioned in the Western concept cannot be applied in the Eastern setting. So there are still a lot of work to be done in terms of linking the culture with the medical humanities. And of course, faculty development is very important because our faculty will need to know the medical humanity parts as well while educating the students.
Yes, of course.
All right. Thank you so much for Dr. Chen for your presentation on this. And I would like to invite my colleague, Dr. Jillian, to introduce the second speaker. Over to you, Jillian.
Thank you.
Thank you very much.
Sushi.
Thank you.
And thank you, Dr. Chen. So right now we'll move on to our second speaker, Dr. Philip Stanley. Dr. Philip Stanley is from the Department of Ophthalmology and Visual Sciences with the Big Park Hospital, and he'll be sharing with us a randomized control study of the effects of daily mindfulness meditation in Singapore medical students. So over to you.
All right. Can you see my slides now?
Yes, we can.
My volume. Can everybody hear me?
Yes.
Okay, good. Yeah. So again, just to go over the title of this, it's the effect of daily mindfulness meditation in Singaporean medical students, a randomized controlled trial. This study was started in September of 22 after DSRB approval. The other helper on this study, I designed the study and did the study, but when I was having Noah Lim rotate through my clinic, he signed up for the study. He goes, by the way, can I help you with this? I said, yeah. And so he's done a lot of the heavy lifting on this also. He's at LKC School of Medicine. Very motivated medical student. He's going to be a great doctor. So anyway, let me try to advance. Okay. And let me get out of here. Yeah, so mindfulness, some introduction, some background and rationale. Mindfulness is the practice of paying attention to the present moment with openness and non-judgment. It's been shown to enhance mental well-being, focus, and stress management. Medical students face a high stress environment, psychological burdens, especially in their clinical years. And among final year medical students, a previous Singapore study reported that 27% experienced anxiety, 25% experienced depression, and 30% reported high stress levels. Traditional mindfulness programs, that is mindfulness-based stress reduction, are effective but time-consuming and hard to fit in the medical students' schedules. App-based mindfulness offers a time-efficient, scalable solution. So what was our study objectives? I wanted to see if a brief app-based mindfulness practice can improve the dispositional mindfulness in medical students. What was the intervention? The intervention is a 10-minute daily guided meditation via the Waking Up app. And my control was listening to a reflective audio essay of the same duration in the same app. The primary outcome are changes in scores on the Mindful Attention Awareness Scale, MAAS. And again, the aim is to assess whether even a short daily mindful habit can yield measurable improvements in mindfulness over 2 weeks. Okay, so what I want to do now is, what I want to do now is just introduce Sam Harris's app. For people that don't know Sam Harris, he's the author of 5 New York Times bestsellers, including this thing called Waking Up, a Guide to Spirituality Without Religion. He's written on a wide variety of topics: neuroscience, meditation, moral philosophy, religion, rationality, but in general, he focuses on growing understanding of the world and how we should live in it. And who is David White? David White is the controller of my study. David White is an internationally renowned poet and author of 10 books on poetry. These books on prose are transformative and widely acclaimed. He also has an extensive audio collection. What I want to do now is we're going to take a break for a moment and listen to Sam. This is an example of his app, and we'll introduce you to him. By the way, I've been a lifetime member of his app, and so if anybody's interested in a 30-day free trial, all I need is your email, and I'll be glad to sign you up. If you go online, you're going to only get a 7-day free trial. If you go as a member, you get 30 days to practice this.
Hi, this is Sam Harris. Welcome to the Waking Up app. I want to take a few minutes to give you a sense of what you'll experience here. The purpose of Waking Up isn't just to help you meditate. It's to help you live a more fulfilling life altogether. To that end, there's no shortage of resources you can explore in the app, including dozens of conversations with philosophers, scholars, and contemplatives. There's a wide range of courses with highly regarded meditation teachers. There are discussions about psychedelics and sleep and happiness. There are lessons on stoicism, effective altruism, time management, and more. And the list of topics we cover is always growing. But I encourage you to start here with our introductory meditation course, which may differ in a number of ways from other meditation resources you might have used. The course is structured in a step-by-step way over several weeks. Meditation isn't a quick fix. It's a practice. It's a growing perspective, really, that you train in and become more familiar with over time. The course alternates between theory, lessons that explain the why of meditation, and practice, the meditation sessions themselves. So you're not just learning to meditate, you're also learning to incorporate the insights you're gaining into your daily life. The meditation technique you'll be using is a form of what's commonly referred to as mindfulness. But with our approach, we're not merely helping you calm down or reduce your stress in the moment. You may very well experience those benefits, but really we're teaching you how to observe the nature of your own mind so that you can discover some fundamental truths about it. Your mind, after all, is the basis of everything you experience in life and of every contribution you can make to the lives of others. Given this fact, it makes sense to train it. You already know what it's like to have an untrained mind. We all do. It's what allows us to be less than happy even when things are about as good as they can get. Even when everything is fine, we spend most of our time thinking about all the things we need to do, or want to do, or wish we hadn't done. And we spend very little time truly content and focused in the present. And because of this, we often fail to really connect with the people around us, even the people we love most in this world. Understanding your own mind directly through the practice of mindfulness is the best way I know of to correct for this. There's another aspect to mindfulness, one that is more profound, and that can radically change your perspective on life. And this has to do with discovering a sense of freedom that is intrinsic to the nature of your mind, and that is therefore always available, even now.
It looks like I lost connection to the internet. So let me let me move on. Once we get connection again. So anyway, that was a little bit of Sam. So here's the study design. This was a single center randomized prospective clinical trial at KTPH's Department of Ophthalmology involving medical students, both from NUS and NTU. These are third and fourth year students, age 21 to 25, full-time students. They all use a smartphone. The inclusion
Dr. Philip, sorry to interrupt. Are you having issues sharing the slides?
Yeah, sorry about that.
Maybe I get my colleague.
I got to get back. Yeah, because I had a little internet. Interruption there.
Su Ping, will you be able to assist to share the slides?
Let's see. Usually, why can't
Have to send me.
Okay, let me get to my big screen here again, sorry.
No worries. Thank you.
Yeah, I'm working on the hospital's system here. I need to open up the presentation again. There it is. Okay. Let's. Why? Zoom. Back to meeting. Okay. Share. There we go. Okay, good.
Yes, great. Thank you.
Yeah, I mean, IT is always the biggest challenge of any of these presentations I've found. You can have the best intentions. Yeah, so the one thing on these slides, I just want to mention the null hypothesis is that there is no difference between mindfulness meditation and listening to a short essay. Okay. Who else has done stuff like this? Schools that have incorporated mindfulness have this German university, they did an 8-week mind-body medicine stress reduction program. And on the course completion, there were measured improvements noted in the health related quality of life, perception of stress levels and behavioral reactions. In the US, St. Louis University School of Medicine added a wellness program, included resilience, mindfulness training to the curriculum, and it observed decreases in stress, anxiety, and depression among their students. And finally, Georgetown University School of Medicine introduced an elective course in mind-body medicine, and there was a decrease in perceived stress and increase in mindfulness and concern for the well-being of others. So again, back to the study, I wanted to get about 104 students. That accounts for about a 10% dropout, and that would give me a power of 85% with an alpha of 0.05. There was randomization. I did it with this randomizer.org. It was unblinded. The SAM group got a 10-minute daily mindfulness meditation based on that waking up app you listened to. And the David group listened to David for 10 minutes. And so that was our control. I like that because they're on the same app and they're doing pretty much the same thing, but different styles of the program. So what was the outcome measure? We use this thing called the MAAS, the Mindful Attention Awareness Scale. It's a 15-item point, and the typical scores are about 57.75 for undergrads, 65 for experienced meditators, and 64 for cancer patients. You might want to say, what's with cancer patients? They're facing mortality, so it allows for increased mindfulness practice, and with it, the adherence to the suggested treatments recommended. There are psychometrics. This study, this MAS, has a well-validated internal consistency of Cronbach's alpha of 0.82 to 0.89. And then it also has good retest reliability. It's called the ICC, interclass correlation coefficient of 0.81. Here's an example of what the MAS looks like. 15 questions. The students will do this at the beginning before they start the study, and then after they're done the study in 2 weeks, they do it again and would get it back to me. How did I measure the stats? We used descriptive stats performed for baseline analysis. We used Cohen's D to measure the effect size. And then a 2-sample t-test was used to compare changes between Sam versus David, the two schools, NUS versus LKC, male versus female, while a paired t-test compared changes within the group, where P was less than 0.05. A correlation analysis was performed between continuous variables, and a regression model was applied with a change of score as the outcome. What are the results? So again, our demographics, so far, again, this thing was calculated. I still have about 4 or 5 students left to finish my 104. So far we recruited 94 as of today, with 50 female, 44 male, and 64 completed a post-test. There was about a 32% attrition. I'll get to that later. 30 female and 34 male. So with the randomizer group, we put 30 in the mindfulness group and 34 in the David group. 40 from LKC, 52 from NUS. Completion rates about the same, about 70 and 71.1%. Yeah, there was really, as far as the validity of the randomization, there's no gender imbalance. There was no gender differences from either baseline or post-test. As far as the control group, they had actually a higher baseline mindfulness, and that was statistically significant. But between the LKC and NUS groups, there was no statistical significance. What's the results? Here, as you can see from the bar graphs, the SAM group definitely had a delta of 11.16 versus about 1.19 over the David group. That's and just this is the overall comparison by groups. So SAM, our mindfulness meditation, definitely was statistically significant over the 2-week period. Comparing schools, NUS versus LKC, it looks like the even though NUS started out with a lower score, the delta of 9.08 was actually higher than the LKC group. This suggests that maybe the NUS students may derive greater benefit from the brief mindfulness interventions. So, with discussion. So this was a brief daily mindfulness practice, and it significantly improved mindfulness level versus active control among these medical students. The SAM group showed statistically significant greater increases in mindfulness. Results are consistent with prior studies showing benefits of short-term mindfulness. This highlights the potential for app-based intervention as a time-efficient and scalable tool. And it suggests that the MAS shows improved self-awareness, emotional regulation, and autonomy just in the 2 weeks. And this may help buffer students against the academic pressures and clinical stressors with medical school. School differences, again, as I mentioned, it may reflect differences in academic structures and stress levels. It was commented that NUS has frequent assessments that may potentially higher stress and greater responsiveness and mindfulness than the LKC students. Yeah, no significant gender differences. This is so it's applicable across genders. The limitations, it was short duration, limits ability to access long-term stability. It was unblinded. It may introduce expectancy bias. High attrition rates. Yeah, I expected about 10% not to return the questionnaire, but 32% did not. Yeah, so what would happen is I would remind the students, hey, in 2 weeks, your post-test is due, and send it to me on WhatsApp. And a lot of times I had to remind them 2 or 3 times. Sometimes the 3rd attempt worked, but sometimes it didn't. After 3 attempts, I gave up. And so that I was unable to use that data. And that potentially reflects the challenge. These medical students are busy, and my clinical study may not have been the top priority for them. Yeah, and future studies may include objective markers, something like stress hormones, attention tasks, checking cortisol levels, for example, could be a way to check this. Yeah, and again, this is the generalizability is limited to Singaporean medical students, and we could include broader populations. So in conclusion, what's some future directions? This was the first randomized placebo-controlled study of mindfulness medication in Singapore medical students that we are aware of. It's a brief app-based mindfulness medication, and it definitely improved the mindfulness of Singapore medical students. A medium effect was observed just in 2 weeks. The differences in schools might highlight an influence of educational context, and it's this supports a flexible digital wellness tool into the medical curriculum. So again, long-term studies. What's the optimal dose of this? Okay, compare app versus in person, group versus individual. Does this have an impact on clinical skills, empathy, and stress biomarkers? Maybe include a qualitative feedback on our user experience, and maybe expand it to a multi-center, multicultural trial to enhance the generalizability. Thank you very much.
Thank you, Dr. Philip, for a very relevant study that you have conducted. And to our participants here, please feel free to put your questions in the chat if you have any. Out of curiosity, Dr. Philip, is this app currently available for students, or is it free for download?
You can get, as I mentioned, if you go on the internet, you can get a free 7-day trial if you just get on. But if for example, I'm a lifetime member. I signed up during the pandemic, and I've been doing this myself since 2019. It's been a real addition to my lifestyle. I do it 10 minutes every morning after I wake up. And so if you want a 30-day pass, all you do is you send me your WhatsApp. I send you that link from my app, and then you can download the link and have 30 days of free reign on the app. And go through everything. They have things like conversations, Stoics, Dalai Lama type people, really cool things that you can listen to, experts in meditation, sleep experts, just a whole variety. But to do the actual meditation that he does, you have to go through the 50-day course. And each day you go through a different lesson. And once you get through that 50 days, then you're allowed to go free reign and go through his course any way you want. And then I get what's called a daily meditation every day. It's a different meditation, and it's Sam talking for usually about 10 minutes. So anyway, again, anyone in the audience, just shoot a message to me or one of you people at SEMmed, and I'll be glad to send you that 30-day access. And again, it's one of these things that you try it for a while and you just kind of grow. You keep growing and you like it more and more. And you learn. I'm learning things I never knew about myself.
Yeah. Thank you. And I believe for any participants that are interested, please feel free to reach out to Dr. Philip or SEMmed staffs. There is a question from Sushi. So what makes this app different from others, and why was this app selected for this particular research?
Well, again, I just kind of told you get a 30-day free trial. Okay. A lot of these other apps are teasers. I've tried some of these other ones, and they basically give you like 2 or 3 days, and then all of a sudden they want you to enter your credit card details.
I see.
So that was the main thing. And plus, if you've ever listened to Sam Harris debate anybody or talk, this guy has probably one of the best vocabularies I've ever seen. He can talk off the top of his head about almost anything, and he has the way he talks, it's a slow, thought out way. And so the way you listen to him, it's just an intelligent way. And then also David White, I wanted everybody to get exposed to David. Let me see if I can, I'm back online now. I wanted, if everybody has about 2 minutes, I'm going to have you listen to David here.
Uh,
Does
Dr.
everybody?
Stanley, yeah,
Yeah.
as we are keeping, because time is a little bit short,
Yeah,
so
okay.
perhaps you can put it in the chat for our participants to have access to if there's a website for it or app.
Oh, you got to pay for the web. You got to pay.
I see. All right.
Yeah. Yeah.
So for participants who are interested, you may have a listen to the app that Dr. Stanley just mentioned.
Yeah.
We have
like
two
I
more
said,
questions. Yes.
You can get a teaser. You can get a teaser online, but it's nothing like a 30-day free
I
trial.
see.
Yeah.
Got it. We have a question from Kwadwo. So he would like to ask, can you describe a little bit about the group that was lost to follow up? And do you have data about the baseline religious or spiritual backgrounds and practice of the participants?
Absolutely not. That wasn't part of the study.
Right.
Yeah.
I see. So
Yeah.
there was
Basically, we got medical school, age, and sex. That was basically it. That was the data. That's
I see.
demographics. Okay.
Got it.
Yeah.
Okay. One final question for myself is, was there any particular characteristics of the students from NUS that you felt had made them more receptive to such mindfulness activities?
Yeah, I mean, I not so much among each students, but groups of students were very funny. Because the way I recruited a lot of the students was in my teaching in the morning. I would do a teaching session on eye disease. And we usually have 5 or 6 students that would be in the class. And it was just amazing the diversity between not just LKC and NUS, but between groups. It seems like if one person signed up and was keen, the other people were ready to go. But if I said who's interested in the study and no one raised their hand, nobody signed up. And so it's just almost that kind of herd mentality, whereas if one brave soul raised their hand and says, yeah, I'm keen. And then all of a sudden you look at somebody else, hey, yeah, I want to do it. Yeah, I want to do it. So that was the main thing I noticed.
I see.
Yeah, it was interesting. So it really showed a group dynamic in a group of 5.
Got it. So the group's influence on each other does make a difference.
Yeah,
on the
yeah.
receptiveness.
Some days I wouldn't sign students up for months.
Mm.
And then other weeks I'd be signing up 5 people, a
At
week. It was just different. Yeah.
All right. Okay. So thank you, Dr. Philip, once again for your sharing. As we have reached time, I will just end the conversation here. But if our participants have any interest, they can reach out directly to you. So I'll hand it over to Sushing to wrap up the session.
Thank you, Dr. Stanley, and Dr. Chen as well for today's presentation. So, sorry, Dr. Stanley, I might need to, okay, all right. So next month, we have 2 presentations, okay? One from Taiwan as well, and the other one from our own Department of Pharmacy, National University of Singapore. So Prof. Chui and Dr. Chow will be presenting in our next September Prime session on 8th September 2025. So the time remains the same, 12:30 to 1:30. I hope to see all of you during this segment as well. So see all of you soon. And thank you so much for joining us today.